we're going to shift gears just a little bit, or largely, and we're going to talk about post-arrest care. Joining us next is Dr. Tarlan Hedayati. Dr. Hedayati is Associate Professor and Chair of Education in the Department of Emergency Medicine at Cook County Hospital in Chicago. This is a very, very large department of emergency medicine, one of the really long-standing departments in our specialty. They have a large residency program with 68 residents, 30 faculty, and she's in charge of education for all of these folks, as well as for the third and the fourth year medical students that rotate through the emergency department. Dr. Hedayati is truly one of the outstanding educators, well-recognized outstanding educators at the national and international level. In 2019, 2020, she received ACEP's Outstanding Speaker of the Year Award. And, well, just summarizing, I would say that she's really one of the go-to speakers whenever people anywhere are looking for outstanding educators to come and speak at their emergency cardiology conferences. And I've learned so much from listening to her over the years. So, Tarlan, thanks for joining us. And let's turn it over to you to talk to us about what best practices in post-arrest care are.
National audience. And I've been listening in on the live stream, some amazing talks. And if, like me, you have literally hours from now, as I'm going to be walking into my next shift. So yeah, we're going to be focusing now for the next 30 minutes on current concepts in post-ROSC care. So return of spontaneous circulation, you've achieved it, now what? So you have a patient, they arrive via EMS. He was at a nearby grocery store when he collapsed. EMS was activated. Fortunately, there were some bystanders nearby, as is typical in a grocery store, and they checked for a pulse. They didn't feel anything. They started CPR immediately. They couldn't get an AED located in time to get it to the patient's side, but fortunately, the paramedics are actually just a couple of blocks away at their station. And so they are able to get there within minutes, and they're able to put their pads on. They see the patient is in ventricular fibrillation, and they go ahead and they defibrillate once in the field. He gets the standard medications that he needs. They scoop him up and they bring him over to us in our emergency department. Transfer him over to our gurney, get our pads on and our leads on, and we see that he is still in ventricular fibrillation. And so he's being bagged, by the way, through a supraglottic airway at this point. And so we see he's in VFib, and so we go ahead and we defibrillate again. This time, patient goes into a narrow, complex sinus rhythm. Woohoo! Someone yells, "I feel a pulse." And you are like, yeah, another life saved. High fives all around. Everyone's smiling. You're basking in the accolades. And this is your mic drop moment, right? Like, you did your job. You did it well. You're getting ready to walk away, right? Like, you're done. Not so fast. Your work has actually just begun, friends. So we've heard about the golden hour of trauma, which is that first critical hour of patient care in trauma, that resuscitative trauma care. And we can extend this to other aspects of emergency medicine, so including medical resuscitative care. And so now, we need to think about kind of that golden hour after the cardiac arrest patient actually has return of spontaneous circulation. Now, what we do is going to be tailored to our specific patient. But we are going to discuss some general points that we all need to consider in our patients in that golden hour. So first and foremost, I told you he came in with a supraglottic airway. So you want to secure the airway if it hasn't been. Now, if the patient comes in with the supraglottic airway and you're still in the process of resuscitating them, by all means, leave that airway in place. So you do not need to be changing the airway at that point. We have really great evidence that shows that the supraglottic airway is as good as the endotracheal tube during resuscitation. But now that we've achieved ROSC and your patient is maybe bound for the ICU, maybe bound for some imaging, maybe they're going to the cardiac catheterization lab, it's best for us to secure this airway in the emergency department with an endotracheal tube. So that's going to be something we're going to want to do immediately post-ROSC. The next thing is start gathering the data points you're going to need to take really great care of this patient. So the pulse oximeter is kind of a no-brainer. Everybody knows to put that on, and a data point that we have readily available. One thing I want to make sure everybody's aware of now, we're really good at muting alarms in the emergency department. I like to mute monitors and vents and stuff. This is one point or one juncture of your resuscitative management that you're going to want to engage all the senses, including sound. Don't engage taste. Don't engage taste in resuscitative care, but definitely sound. And so the beauty of the pulse oximeter when the sound is on is, one, I'm going to hear when the patient is desaturating. I'm also going to hear if they're becoming bradycardic, and I'm also going to hear if they're becoming abnormally tachycardic. And so this is going to be helpful. If I'm not immediately at the bedside, I can keep an ear out for this patient. The other data point you're going to see on this monitor is your end tidal capnography. This is a must. So during cardiac arrest resuscitation, it gives me an indication of how good the compressions are. And so if I start to see that end tidal CO2 kind of dropping, then I know that maybe the person doing the compressions is potentially getting fatigued and I need to switch them out. When I see a sudden rise in that end tidal CO2 during the resuscitation, I know that that patient's probably about to get ROSC. Well before a pulse check, when you see that end tidal CO2 go up during your resuscitation, they're probably about to achieve ROSC. So that's great. And I'm going to know that earlier. The end tidal CO2 at 20 minutes of CPR is also useful as a prognosticator. So end tidal CO2s over 20 at the 20-minute mark, so 20 at 20 over, is associated with a higher chance of ROSC. And so then I know, okay, I'm going to keep working this patient longer. It also might help us kind of figure out when we need to terminate, but we're going to be talking about ROSC here. Now, remember that end tidal CO2 is dependent on ventilation and pulmonary perfusion. After I've gotten ROSC and I put my patient, I tube them, I put them on the ventilator, my ventilation is now kind of set and it's a constant. So the end tidal CO2 at this point is reflecting my pulmonary perfusion. And what determines pulmonary perfusion? Cardiac output. So end tidal CO2 becomes this sort of indirect measurement of my cardiac output, which is great. So if I see that end tidal CO2 suddenly drop, then I know my patient is about to arrest again because I know their cardiac output has dropped and I need to mobilize my team again to the bedside. So end tidal capnography, the waveform capnography, a must post-ROSC. The next question you need to ask yourself is, how quickly can I get the patient out of the emergency department? And so hopefully they're ICU bound, but another great location for them is possibly the cardiac cath lab. So does your patient need cardiac catheterization emergently? And kind of the best piece of information you're going to have to make that decision immediately is going to be your 12-lead ECG. So if you haven't gotten it, this is the time to get it. We know that up to a third of ROSC patients have a STEMI on that first ECG after they arrest. So even more are infarcting that don't have ST elevation. But these STEMIs, this is like proverbial low-hanging fruit. And now you have a disposition for the patient. So get that 12-lead ECG right away. This is a nice little algorithm published in JACC. That top QR code will link you to the article. And it helps us delineate which cardiac arrest patients need the cath lab emergently. And as you can see, so all STEMIs should result in an activation of the cath lab if that's an option at your institution. So that's an easy one. The end STEMIs are a little more challenging. The COACT trial, which is linked to the QR code below, so the second one, the bottom one, showed us that there isn't really a clear benefit to immediate angiography in those out-of-hospital cardiac arrest patients who achieve ROSC but don't have a STEMI on their 12-lead ECG. Now, that's not to say that they shouldn't undergo angiography at all, but it really calls into question when that angiography should happen. So the way I like to strategize this is I will still call the interventionalist and have a conversation with them. No knowing that if there's no STEMI, ultimately they need to decide if the patient's going to go or not, but that the STEMIs for sure we should be capturing, and we should be trying to push those patients to the cardiac cath lab. If this arrest is likely due to an ischemic event, you want to make sure you've had that conversation with your interventionalist and maximize the chances for your patients for a positive outcome. Now, the gray box that's in the center bottom portion of the slide, that really delineates which patients are probably not going to benefit from the cath lab or from emergent PCI. And those are they're kind of obvious patients that are just never going to do well with a stent. It's not going to reverse their problems. Ultrasound. I know you guys got an amazing lecture from Haney first thing in the morning about the use of ultrasound in cardiac arrest. This is also amazing in that post-ROSC window. This is one of the first things that gets rolled to the bedside when we hear that a patient is coming in with cardiac arrest. And if you have, you're lucky enough to have more than one machine in your department, just leave this one at your patient's bedside who's achieved ROSC. So now that you have ROSC, we want to look for possible causes of the cardiac arrest, especially those time-sensitive, kind of reversible causes of cardiac arrest. So put that probe on. Do I see a big effusion that I can drain? And I see tamponade physiology. I can fix that. Do I see RV dilatation that's concerning for a PE? Maybe I can get that CT, or maybe they're actually going to need thrombolysis. Do I see aortic root dilation, or am I seeing some aortic insufficiency that's suggestive of dissection? I need to mobilize my cardiovascular surgeons in-house. Do I see regional wall motion abnormalities? And so that, might be suggestive of ischemia. That's a data point that I can then pass on to my interventionalist. Says, hey, I know it's not a STEMI, but look, I've got regional wall motion abnormality on echo, and kind of make the push for the cath lab. Do I see a big thick septum on echo? And maybe this was a hypertrophic cardiomyopathy patient that hadn't been diagnosed. So really this ultrasound machine at the bedside has been a game changer in terms of helping us figure out what caused this arrest, and then tailoring the management in that post-ROSC period. An arterial line, much like end-tidal CO2, is a must. And so as you're sort of making your way through this golden hour of post-ROSC care, the art line is definitely something that you're going to want to prioritize. So this is going to give me my most accurate idea of the patient's blood pressure, more than a manual blood pressure cuff or the automated blood pressure cuff. And also, if the patient rearrests, which happens frequently in these post-ROSC patients, it's going to give me a better idea of how good my CPR is, right? So I'm going to be able to see those waveforms. And then I don't even really need to do pulse checks, right? So when we stop CPR to see if there's a pulse, I'm just going to be looking at my waveform to see if there's pulsation. The other perk of this, it allows me to send frequent ABGs if I need to keep an eye on that. And then I also get to send other diagnostic studies. So now I don't have to poke the patient so frequently. The patient will appreciate it. The nurses will appreciate it. They can just draw right off the art line and send whatever additional labs you need. If you're checking lactates frequently, if you're checking troponins frequently, you can do that all off of your arterial line. Now, this particular image shows a radial arterial line, but I want to really make the push for femoral arterial lines here. They're way easier, particularly in these, shocky post-ROSC patients. So just go ahead and put that fem line in. The other push I want to make is, we talked about ultrasound. Please use ultrasound when you are putting these lines in. So again, a pulse may be difficult to palpate if the patient is shocky. And the few seconds you spend putting that probe on to see where the artery is to stick is going to save you like minutes and minutes and many minutes later on when you're like continuously poking to try to find that artery. So art line is a must. Fem art line is really the way to go. So now you've got your patient here. You've achieved ROSC. And maybe they are starting to get a little more hypotensive. So what happens? We give them all sorts of agents, particularly epinephrine, during a lot of our resuscitations. And a full 50 to 75% of your post-ROSC patients are going to experience some shock. And all that epi you gave during the resuscitation it's going to wear off, so it doesn't hang around forever. So we need to think about how are we going to support their blood pressure. Now, if all you have is a peripheral line or an IO, keep it, stick with it. So in this first hour, you don't need to be messing around with a central line. You can use the peripheral lines or the IOs that you have to infuse your vasopressors. You can think about a central line later after this golden hour, or even if the patient has moved on to the ICU. Now, we want to maintain perfusion, coronaries, brain, kidneys. These are all like super important. What's the best agent to use? And so this is where the catecholamine throwdown happens. And really the two big agents we tend to reach for most frequently are going to be Norepi versus Epi. Now, which is best? I'll tell you personally, I typically reach for Norepi. And this is purely because it's an ease of use perspective. Norepi is available in my emergency department. It's already made. The nurses just have to spike the bag and put it on the pump. Super duper easy. Epinephrine has to be mixed by the nurses, or it has to get sent up from pharmacy, which is going to cause a delay. And being the person that I am, I will not accept that delay. And so Norepi is really my go-to agent. But am I really making the right choice here? So is convenience really the way to go? The study in the QR code in that lower left-hand corner, published a year ago, so March 2022, looked at this very question. So Norepi versus Epi in post-ROSC patients who are hypotensive and shocky. And what they found was that patients on Epi infusions post-ROSC had higher all-cause mortality, they had higher cardiovascular mortality, they had higher mortality related to refractory shock, they had higher recurrent cardiac arrest, and they had poorer neurologic outcomes compared to the patients that had been on Norepi drips. So obviously the study, when you take a look at it, you'll find it's not a perfect study. And there were some confounders in there, but it does make us reconsider that knee-jerk reflex that a lot of us have to reach for epinephrine immediately. So give Norepi a try. And again, thankfully, my ease of use for Norepi turned out, at least according to the study, to potentially be the better agent in that post-ROSC patient. If you go with Norepi, typical dosages you'll see is 0.2 to 1 mic per kilo per minute. I like to keep it simple. I'll start at 10 mics per minute, and then I am standing at the bedside with the pump and I am cranking it up as needed. You don't want to wait for the patient to suddenly drop their blood pressure before you're doing these things. So as soon as you start to see that they're maybe starting to make their way down, get these agents on and start bringing that map up. Your goal is going to be about 60 to 65. That's what most of the guidelines will recommend. And the best outcomes have been associated with trying to achieve that map in the post-ROSC window. If you decide to go with the Epi infusion, I like to start low. So I'll start at 2 mics. I'll make my way up. You can certainly start higher, especially if your map is already very low. So you can start at a higher dose, start at 10, start at 15, and then come down or up or tweak it as needed. But I like to catch them pretty early, start at a lower dose, climb my way up. One thing I want to mention is with these agents, oftentimes you'll see, ceilings of dosages that are maybe in your guidelines, even at your hospital, or, if you look up doses on your phone. Those ceilings do not exist for us in this golden window, this golden hour of resuscitative care. So if you need to keep cranking up, by all means, crank it up. And if you need to add another agent, then add another agent. But don't worry so much about the max dosing of these drugs when you are in this post-ROSC window. The third agent to think about in terms of supporting blood pressure and cardiac output is dobutamine. So if you have a patient who's particularly in cardiogenic shock, you may need to use a little bit of dobutamine to help augment that cardiac output. This is not an agent that I would start by itself. So this is one that you're going to want to use in conjunction with one of your other vasopressors to help boost that cardiac output and get those maps up for you so that they can perfuse those coronaries, especially really, really well. Let's talk a little bit about sedation. So this is something we're not awesome at. Oftentimes we, in that arrest, window, we sometimes will intubate without sedation, without paralytics, because the patient is in an arrest situation. And we feel like maybe they don't need it in that moment. But definitely after you've achieved ROSC and you've intubated the patient, and you need to think about analgesia and sedation. So very, very critical. We know that a lot of these patients report hearing things, remembering things when we thought that they were comatose. And so what are the sedative agents that we want to think about? So ketamine, the darling of emergency medicine, great choice here, has positive hemodynamic effects. It's a dissociative, it's got analgesic properties. So you get pain control out of that, you get anxiolysis, you get amnesia, and you've got a patient who just got chest compressions, you're about to do painful procedures like art lines, you're intubating, maybe you're dropping an NG tube. If you're going to put in a central line, these are painful procedures. And so we want to make sure that they're adequately sedated, and we've provided analgesia. Fentanyl, another great option. So less hemodynamic instability compared to some of the other opioids. It makes it a really good analgesic choice. Superior to the benzos in terms of causing hypotension. And the other great thing about fentanyl is it doesn't rely on the kidneys for clearance. So it's metabolized through the liver. And so it's not going to sort of build up, particularly in your patients who've taken a hit to their kidneys. So once you turn it off, it'll be off. Midazolam, good choice as an infusion. It's a pretty good sedative. It provides no analgesia. So just be aware, this is one that I will use with fentanyl to then kind of augment sedation, and I'll get my analgesia from the fentanyl. So I don't like to use midazolam by itself. And then the last thing to mention here is dexmedetomidine, another possible choice. Again, relatively hemodynamically stable and neutral when it's used as an infusion, not as a bolus. And if you have it, it's a great option. It provides the sedation and the analgesia. I personally don't have access to it, but if you have it, then this is something that I would use if I had. The perk of dexmedetomidine is its ability to sedate while maintaining arousability. So your patient is sedated, but when you stimulate them externally, they're going to be arousable, which is great if you need to kind of assess their neural function, regularly or frequently or soon. So fluids, who doesn't turn up the fluids as soon as the arrest patient comes in, especially if they're a little bit shocky? Just be mindful of how much they're getting. We want to fill the tank if it's needed, but just be aware this patient's pump, their heart is probably not working properly. And so their cardiac output is not as adequate as we would like it to be. So all this fluid that you dump into them could actually end up causing more harm than good. It's going to third space. It's going to end up in their lungs. It's going to end up in their bowel wall, in their peritoneum. And that's not good for anybody. So give fluids if it's needed, but just you don't need to flood the patient. So now you've had some time with the patient on the vent, and we just had a really great ventilator lecture. Should we be doing something? Should we be adjusting the vent at this point now that the patient's been on it for a little bit? So the first thing I like to do is take a look and see, do I have an opportunity to decrease my FiO2? And this is going to be based on my pulse oximeter and my gas. We really need to think about oxygen as a therapeutic agent. And so you want to titrate the right amount to the patient based on what they need. The QR code in the corner there, so evidence that hyperoxia post-arrest actually harmful. So in fact, based on the study that's in that corner, for every hour of hyperoxia post-arrest, the risk of poor neurologic outcome increases by 3%. 3%, that's a big deal. So this was a study, it was close to 300 ventilated post-arrest patients. They had their arterial oxygen checked at the 1 hour mark and the 6 hour mark. And 77% of those hyperoxic patients had a poor neurologic outcome compared to 65% without the hyperoxia. The number needed to harm for this study was 8. So that's really low. We don't need to be aiming for 100% sat on the pulse oximeter. So mid-90s is great. The other thing this study found was that the pulse oximeter didn't correlate well with blood gas oxygen readings. So this is another great reason to get those art lines in really, really early. So titrate titrate that FiO2, sort of aiming for mid-90s pulse oxes. The other thing you're going to want to adjust on the vent is going to be based on your CO2 readings on your blood gases. So remember, normal is 35 to 45, so right around 40. And if your CO2 is low, it's indicative of alveolar hyperventilation. So that low PCO2 is actually going to cause some vasoconstriction. And vasoconstriction happens everywhere. Where we don't want it to happen is in the brain. So you're going to cause cerebral vasoconstriction and therefore cerebral hypoperfusion. And that's not good, particularly when we're looking at neurologic outcomes. So you may need to reduce that respiratory rate on the vent to fix that PCO2. If the PCO2 is high on your blood gas, then you are hypoventilating your patient. And it's going to have the opposite effect. It's going to cause cerebral vasodilation and even potentially increase that ICP. And so we don't want that either. So you may need to actually increase the rate and blow off some of that CO2. So the 35 to 45 is our sweet spot. Adjust your vent to kind of aim for that based on your blood gas. Some tubes you may need to kind of put in at this point. So an NG and an OG is really helpful here, helps decompress the stomach, maybe even improve ventilation because it'll allow for that diaphragmatic excursion. And then we talked about being judicious with fluid administration. A great way to gauge how well the kidneys are processing that fluid is by measuring the output. And the way we're going to do that is with a Foley. This is pretty standard in the ICU, but sometimes in the emergency department, we forget this. The benefit of the Foley catheter is a lot of times it comes with the temperature probe. And so then you're going to be able to get a core temperature off of that Foley as well, which then shifts us into talking about temperature and what is targeted temperature management evidence at this point. Most guidelines still strongly recommend a target between 32 and 36. We are moving away from 32 and really kind of leaning in towards 36 and really just euthermia or normothermia in the post-cardiac arrest patient. The overall evidence isn't great. The study that's linked in the QR code in the corner is the TTM2 study. That was published about 2 years ago. And it was like close to 2,000 comatose patients post-arrest who were randomized to either a targeted hypothermia at 33 degrees or just targeted normothermia and then fever management as needed. And what they found was there was no difference in terms of the primary outcome of death at 6 months and no difference in functional neuro outcomes either. In fact, the incidence of arrhythmia that caused hemodynamic instability was higher in those hypothermic patients. So our goal at this point can be kind of normothermia, and cooling measures can be implemented if your patient develops a fever. And so that's kind of our strategy at this point. I want to spend a little bit of time talking about neuroprognostication. Not really something that we should be doing in the emergency department. So unless there's like evidence of brain herniation or evidence of brain death, which we don't normally do in the emergency department, this is not something we should be doing. Most centers that have protocols for post-ROSC care really recommend that this be deferred 72 hours after the arrest. So we don't have a test or a study or a physical exam finding that we in the emergency department that's going to help us neuroprognosticate how well this patient is going to do eventually. So if you get approached by family, by friends, they want, doc, what do you think? How's it going to go? Obviously summarize what happened with the case, get information from the family at that point, but you don't need to prognosticate, that just tell them, we need time for things to unfold and see what happens. We're providing the best possible care. We brought your family member back. You all did a great job resuscitating the patient. Take credit for that, but we're not going to prognosticate. If you have time, this is also kind of towards the end of that golden hour to maybe gather your team for a debrief. So the AHA actually recommends debrief after every resuscitation because it's been shown to improve patient outcomes. And if you do it right after the resuscitation, that's what we call the hot debrief. You can figure out who the facilitator is going to be. Most of the time it's me, but I've been part of some nursing run debriefs. And so, those are done really well so it doesn't always have to be you. It can be another leader within the team that can run the debrief. Choose a location where you're not going to get interrupted a lot. You have a little bit of privacy, but not so far away that you're not going to run to your patient if they need you again. I like to give people a heads up. Hey, I'm going to start a debrief in about 15 minutes. Let's meet in room 5 at that time. I also like to set an end time so that we're not in there for too long. You can discuss the resuscitation itself. So I usually like to start with a summary, and there's like an art and science to the debrief, which I'm not going to get into, but yeah, I like to start with just a summary. And then kind of everybody talks about, what went well, what didn't well. I like to solicit feedback about how I performed as a team leader. And so this is an opportunity for them to give me some feedback. What can I do better next time? And then you want to acknowledge your team and acknowledge the individual team members who did a phenomenal job resuscitating this patient. So we're going to end this on a positive note so that everybody feels good and we can then move on with the rest of our shift in a positive way. And then the last thing I'm going to leave you with is if you develop a post-ROSC checklist for yourself or for your department, it could be one of the single greatest things you do for improving patients who are in this post-ROSC period. Lots available online. You just have to Google it. You don't need to reinvent the wheel. But when you use kind of evidence and guidelines to develop a post-ROSC checklist, then you kind of standardize some of these things for every single patient, and you ensure that every single patient is going to be getting great care. Here's my email and my Twitter handle. I will most definitely be at the panel to answer any of your questions. It's been a pleasure to join you today.
All right, Dr. Hedayati, that was, as always, absolutely fantastic. And here in the command center, we were just commenting on how between you and Corey, Epi's getting quite a bashing today. So we're going to have to talk a little bit more about Epi, whether we should just be tossing it out or what exactly we need to do. Anyway, speaking of Corey, he stated during his talk about Epi that we shouldn't really treat all patients exactly the same way with regards to Epi, but this definitely can be extended to other treatments as well. And